Hello everyone. I hope you are all joined in okay for tonight's event, and I hope that you all hear me okay. My name right. So we are trying this evening a hybrid event, and so my name is Laurent Georgin. And I am the Faculty Student Experience Manager here at King's. Thank you for joining us today for this year's Perseverance Trust Nightingale Fellowship Lecture. I'll just say a couple of points before I hand over to Professor Higginson, who will welcome us all. So I am here in our faculty building at Waterloo, and with me in the room are my colleague Paul Lau, as well as Dr. Christine Taylor, and some of our Nightingale Fellowship trustees. So I hope that the hybrid event and setup is going to work well for us all. For those of you online, please can I ask you to keep your mic muted, but by now you're probably very used to this, so that it doesn't interfere with our speakers. So this meeting as well is recorded, so others who couldn't join us today will still benefit from it. So later in the event, you'll be able to share your questions, your thoughts in the chat, or raise your hand, and we'll come to you. Finally, you may have seen that the event's Twitter hashtag is Nightingale Lecture 22 for those of you who will want to share your thoughts and comments via your networks. But we have a lovely program waiting for us. So without further ado, I will now hand over to Professor Irene Higginson, our Faculty Executive Dean.
Hello, everybody. I'm actually in a room in the Cicely in the faculty, which is a couple of doors down from where everybody is. But we thought it'd be quieter if I did my intro from here, and then I'll be popping back into the other room and staying a bit online. But it's my huge privilege to welcome you to tonight's lecture. I'm very proud that this is my second lecture, so I'm really pleased with that. And I would like to offer a special thanks to the Nightingale Fellowship and the Perseverance Trust for their generous donation, which has enabled these lectures since 2016. I'd also like to thank Dr. Christine Taylor, who's the president of the Nightingale Fellowship. You'll be hearing from her at the end, and some of the trustees who are with us tonight in person and online. Thank you also to our speakers in advance. I'm sure that Avi, who is also online, so it's good to see you, will be introducing them. I'd like to, if I may, and Mary, I'd like you to turn your camera on, please, just to let you briefly see our new Vice Dean Education for the faculty, who's very new into role this year. She's particularly interested in the study that we're going to be hearing about today, the COVID nurse study, because she's been looking at the experiences of student nurses in COVID. So Mary, welcome, and it's really good to see you, and perhaps you'll be engaged in the discussion at the end of the meeting. So thank you. I just wanted to highlight some of the things that our faculty has been doing in the last year. So I'll start by reminding you that last year's talk by Professor Louise Rose was about lifelines, which provides secure connections via smart devices between families and patients with COVID-19 and the clinical team caring for them. Now, the Lifelines project is a very important project for our faculty. It was used considerably not only to connect patients and families, but also to help train clinicians during the very bad outbreak of COVID in India. And it's currently providing some urgent support for frontline hospitals in Ukraine. So we're very proud and pleased about that work. I'll also post in the chat and online later some of our other work that we've done in the last year in the faculty. Particularly important, we're very proud of the fact that we've generated these revolutionary therapeutic drugs that replace the bulky dressings and scarring that many people have to deal with. That's work being led by Professor Patricia Grocott. We've also been looking at how to improve services, particularly nursing support with our experience-based co-design. And we have a flagship trial, which is looking at new ways to help people manage breathlessness that has just recruited its 100th patient across the UK and Europe, which we're very proud about. So we'll pop those aspects into the chat. But what I'd like to do now is hand over to my co-chair, really, Avi Bhatia, and thank you very much for your support and all your collaboration in the last year.
Thank you so much, Irene, and good afternoon, everyone. My name is Avi Bhatia, and I am the Chief Nurse at Guy's and St Thomas's. And this is the second event that I've been in. And I remember the last one. It was the same time, and the sun was shining as well. And we've got the sun again today. And I remember it was very hot and sunny on the last one as well. I'm absolutely delighted to stand here in partnership today with our King's College London colleagues and the Nightingale Fellowship, and welcome you all to the fifth annual Perseverance Fund and Nightingale Lecture that we are holding. And it's so brilliant to see so many people making the time to attend today. You know, as I've already alluded to, you know, the past few years have really been extraordinary times. And the Lifelines is just one of the initiatives that's been an absolute game changer. And we heard about that last time, and Irene's talked about how that's still continuing to make a phenomenal difference to our patients and families internationally. And the pandemic, you know, we've talked about this at the last event, but it continues to have an enormous impact on all of us, both personally and professionally. And yesterday was the National Day of Reflection and Remembrance, and we took time out, as I'm sure many other organisations did, up and down the country and internationally, to remember all our colleagues that we have lost over the last two years, which has been incredibly difficult. Such precious lives lost, and we did have a wonderful service in the chapel at St Thomas's yesterday to reflect and take time to remember. I'd also like to again just pay my thanks really to colleagues and fellow nursing and midwifery professionals who continue to go over and beyond in terms of their support to patients and organisations. But in terms of where we are now, you know, as well as continuing to deal with COVID, because it hasn't gone away, and although it feels like that when you're outside, it certainly hasn't gone away in hospitals, and our nursing and midwifery colleagues are still caring for patients with COVID in our hospitals. Different numbers in different organisations, still wearing PPE. And although, you know, things have improved, we certainly have turned a corner. Particularly, I'm pleased to say, with visiting, you know, we've probably got, you know, more relaxed visiting than we've had in 2 years, and we know what an incredible difference that makes to our patients and our staff. But we're certainly we're certainly not completely through the pandemic, whilst we focus quite rightly on the enormous backlogs that we've got of patients wanting to have their surgery, and the overall implications in population health that we've seen. So, you know, that's sort of where we are at the moment. And also we've been through an incredible difficult time with vaccination, and, you know, the challenges that we had around there in terms of supporting our staff. One of the things that we did do, which I'm exceptionally proud of at Guy's and St Thomas's last year, with support from Jonah and Roisin, co-heads of the Nightingale Academy at St George's, was develop our nursing and midwifery strategy, which we will be launching shortly. And And it really is an incredible strategy developed under such difficult circumstances, really, when people are working incredibly hard. But some of the key themes within that have really sort of come to the forefront is development opportunities for our nurses and midwives in academia and in research, as well as management and clinical practice. So really good to see that. I don't think there were any real surprises in terms of where our staff want us to focus, and that what that tells to me really that it really was developed bottom up rather than us sitting in an office and developing that. So really pleased with that, and we will launch that in the coming weeks. It's, you know, one of the things I talk about a lot, really, and I helped the national launch of the research strategy and priorities with Ruth May. It was earlier this year, I can't remember, time sort of merges into one, is the importance and the opportunities for nurses and midwives in research. Now, we know nurses and midwives support research enormously, but what I'm talking about is nursing and midwifery-led research into nursing practice, more so as principal investigators. So in that vein, you know, we welcomed to Guy's and St Thomas's our very first Director of Nurse and Midwifery-led Research. I have spoken to Mary about that as well, who I can see. Professor Suzanne Bench. Suzanne is going to help us develop a truly visionary academic and research agenda for our people. And I'm really looking forward to working closely with King's College University in terms of more sort of how we develop that with more sort of hybrid roles and breaking those boundaries between academia and an acute provider. So that's really exciting for me. We know, you know, research is critically important to our services, our patients locally and nationally. So I'm really going to be championing that agenda. I'm absolutely delighted today that we have Professor David Richards, who is our keynote speaker today, because we have been part of the National COVID Nurse Study. And when Fiona Hibberts is on the call brought this to me, I thought, fabulous, we have to be part of this whilst not knowing exactly what it involved. But I'm really looking forward to listening to Professor Richards on this. The trial is absolutely incredibly important to ensuring care is evidence-based and is led and informed by research. And it's an absolute privilege for our trust to have been part of that. And finally, I do want to say a big thank you and good luck to all of our speakers today that you'll hear from, but in particular to Jenica, who was the amazing ward manager on our COVID nurse trial ward, and also to Ugo and Sharon, who I did see earlier on the screen as our Nightingale awardees, who I know are going to be absolutely fantastic today. So if I may now hand over to Professor David Richards so we can hear the detail behind the COVID study. I can just see David now, he's appeared. So welcome, David, and thank you so much for joining us today, and we're really looking forward to hearing.
Great, thank you. I'm also looking forward to hearing from you and hearing from other people and their comments. And I'm just say how delighted I am that I've been invited. It's a real honour, and I'm talking about something, of course, which is absolutely appropriate for the title for a Nightingale lecture. So I'm going to share slides. I'm also going to do something really adventurous and show a video at some point. So I've turned my sound up, and I hope everything will work. First of all, I'm going to there we go. I'm hoping that everybody can see these slides now. Obviously I can't see you, so if there's anything goes wrong, please just somebody shout. This is the COVID nurse study, and I want to give you some background. And it is my way, I'm afraid, that I don't always be very scientific in background. I'm often quite personal. So you'll have to bear with me and tolerate me sharing some details about my own life. And just to introduce what we mean by fundamentals of care. And this is a definition from the International Learning Collaborative's website. which is an organisation that's global, trying to encourage us all to think as nurses about fundamentals of care. And it speaks for itself, really. We mostly care for ourselves or our loved ones every day. We often don't even think about it. But when we're ill or injured, we often can't do that. And so we might need help. And we might need help from a health professional or somebody dear to us or somebody else to ensure our most fundamental care needs are met. Now, I've been a nurse for, well, actually 40 years, and I've probably been working in research for about 30 of those. And when the mid-staffers, the Francis report came along, I thought, well, I really should do something about this. I really, could help my profession build up the evidence base for these kind of fundamental nursing care activities. What's the best way to do this, that, and the other to meet our fundamental needs? And then something really weird happened. And if you have a look on the left of your screen, you can see what you will probably recognise as a slightly poorly cardiac artery. A couple of those actually don't look very, quite a bit of stenosis in there. Well, anyway, let me tell you that hurts. And for those of you who've had that experience as I did in 2014, it's not a very pleasant one. And so I was, whizzed into hospital. Now, one of the things about that experience was that the medical care kind of just did what it did, and I had complete confidence in that. And very soon, all that was sorted out, and it left me to then experience nursing care. And there was just a couple of examples I'll cite. So I was lying there in my bed after all the technical stuff had happened, and the night sister came on about 10 o'clock at night. And I just took one look at me, and of course I had a cannula in, and the cannula was flopping about and catching on the sheets and causing me a bit of pain. She didn't even say anything. She just looked at me and she walked out and she came back with a muslin sleeve to put over my arm and hand, and guess what? No more discomfort and pain. On a slightly more personal level, my blood pressure was very, very high, incredibly high actually. So clearly, under those circumstances, you go to the toilet a lot. And so I was certainly weeing for England. Now, you might not believe it, I'm quite a shy and retiring sort of character, and I never actually used a urine bottle before. So that was hard because you're all strapped up and wired up and all that. But the thing is, I kept filling it up. And then I got really embarrassed about this. I didn't want to spill it, and oh, what do I do? And I keep having to ask for another one. Brilliant nurse just came in and said, well, you need 2 of those then, don't you? Immediately my anxiety was reduced and I felt a lot better. The point of those 2 stories is that these are tiny 30-second activities that nurses are doing, but only some nurses did them. So I'd been having this problem for a little while with a cannula, and I'd also been worrying about the bottles, but somebody spotted it and helped me out. Now, on the right of the picture, you'll see rather uncomfortable looking dressing, post-surgical dressing, which was a couple of years later when I was traveling home from a talk somewhere, and one of my fingers swelled up like a sausage, and the infection started heading up my arm. Well, you know where you're going when that happens. So I was emergency admitted to a very prestigious London hospital, not yours, I hasten to say, and was there for 6 days while they sorted that out. Once again, the medical care just kind of did its thing, and I wasn't that worried. But what I was in, again, a similar position, where I got one arm up here and the other arm, pumping 24/7 IV antibiotics. In those circumstances, how does one wash oneself or wipe oneself after going to the toilet? Well, it's a bit difficult, isn't it? And the thing is, during that admission, nobody ever asked me. So the professional nurses were fantastic. They were communicated really well. They were wonderful, telling me what the treatment plan was, what I was doing, making sure I wasn't in pain. The healthcare support workers wheeled their obs trolley in, did their stuff, and wheeled their obs trolley back out again. Into the gap fell some of those very basic fundamental needs that nobody really talked to me about. So who do you think did them? Well, actually, my wife. We were traveling together at the time, and I don't live in London, but she managed to stay somewhere in London and saw me a lot, and so she made sure that those needs were met. In most parts of the world, it is in fact significant others and relatives and friends who do that for people in hospital. And I was quite surprised that even in our advanced societies, with all our advantages that we have, that was still the case. What I'm trying to say here is something called the amalgamation of marginal gain. So that first story reflects the way in which small nursing actions add together, and they're only tiny actions at times. Now, the amalgamation of marginal gains is a model used by athletes to identify components of performance that they can be improved by a small margin. And if you keep doing that to lots and lots and lots of different components, you end up with larger gains. And you might say, well, does that work? Sure does. Look at this. This is the Rio Olympics table from 2016, and Great Britain came second. The British Olympic team adopted this performance model called the amalgamation of marginal gains, put that into place, and we outperformed well above. I mean, okay, money had something to do with it, but that wasn't by any means all of it at all. And we outperformed some bigger countries and some countries with strong athletic histories and traditions. So the idea that we can put these things together and build up a performance model seemed, from my experience, lying in hospital, thinking the impact of these small nursing actions that it had on me, thinking, you know what, that's something that we could do in nursing. And we did some work on that. Here is just, you can read these later. These are some of the papers we wrote from the Essence program, which was about seeing if this was a viable way of thinking about nursing care. And I think we think it is. Let's talk about the COVID nurse project then, trial. Now, you know, I've done the background because you need to understand why we were thinking the way we were thinking. These are our partners. And in this project, we were trying to apply some of those ways of thinking because COVID came along, and we knew from what we'd read in previous pandemics 20 years ago that the people in Toronto had a pandemic. We've had 5 or so examples of pandemics where we've got published nursing literature, and we knew there were some similarities, and we knew what we were going to be facing when COVID came along. Now, I'm going to stop sharing this. It'll be a little gap now, and I'm going to show you a video of one of our patient advisors. I never work without patients and public advisors. And she's just being interviewed and talking about her experience during the first wave in 2020 of being admitted and nursed with an infection, with the SARS infection, with COVID-19. So let me find the video. It's here somewhere. Yes. I hope you can hear this. If you can't, when I play it, then please shout.
Just giving a bit of thought to some of the key issues to me about being cared for on the ward, and probably 3 main things I would reflect.
David,
did overestimate.
David, just to let you know, we can hear it, but we cannot see it.
Ah, right. In that case, I'm going to do it again. You're absolutely right. I played it and I forgot to share it. I think we were used to this now.
I'm sure we're going to get there.
I can't. I've practiced this so much, but I can't. Teams won't let me, I don't think. No.
Oh, something is happening.
Is it? Can you see it now?
We see something, but at the moment, not the video yet. If you want, David, you could send me the link to the video and I could try from my end.
To be honest with you, it's just a headshot of somebody talking. So to be honest with you, just listen.
Okay.
Be cool. Yeah. Is that okay?
That sounds good.
Sounds good, yeah.
Yeah, let's do that. All right. So I'm just going to play it and I'll just ask you to listen. You can just imagine a headshot of this.
Just giving a bit of thought to some of the key issues to me about being cared for on the ward, and probably 3 main things I would reflect. The first thing is that the ward staff did overestimate my ability to undertake any kind of self-care. I was so fatigued that my ability to just even wash my face, clean my teeth, keep myself clean, change out of any clothes. I think I wore the same clothes from admission through till about day 4. That was overestimated. And I'd like to think of myself as a relatively young and fit woman. I understand why that would be, but I absolutely was so fatigued, I couldn't care for myself. I also was unable to eat well, that the food was placed in front of me and was frequently taken away, that I had a lot of symptoms of really bad nausea, which meant not only was I too fatigued really to eat well, I just didn't want to eat. And because of the way that the food was brought in and out of the ward, it was hard for the nursing staff to observe that. I don't think they would have noticed that I wasn't eating on the ward. The second thing I would say is my experience on the COVID ward was complicated by the fact I have a pre-existing medical condition. I have an inflammatory bowel disease. During the course of my stay, no one actively asked me about that, although it would have been fairly obvious that I had some kind of medical background because the size of my file is like a block. So in fact, I think it's in 2. So people would have spotted I probably had a bit of history. And it would have helped if there'd been an opportunity just to share what that meant to me and how much that mattered about managed being in a ward and the difficulties that presented for me. There wasn't an opportunity, and it would have improved my experience if people had understood that I was trying to manage a fairly active inflammatory bowel condition at the same time. And in fact, the second I was well enough to go, I begged to leave the ward because I was really struggling and becoming quite distressed about trying to manage the symptoms of my bowel condition alongside being in hospital. The third thing, and I think this is common for lots of people who've been on as part of the group behind this, was my fear about the family. While I'm on the ward, I'm a patient, but actually in my normal life, I'm a mum, a daughter, a wife, a friend, a sister, and everything else. And the absolute lack of contact with anyone in my normal world was incredibly lonely. I felt incredibly cut off. My mental health is usually great. I'm a bubbly, lively, active person. But suddenly being cut off from all of that support system was a real shock to the system. I found it very hard to pick up the calls when my husband did call. So I'm sure one of the nursing staff did tell my husband the number that he could call in on. And at times people were very kind and would help me facilitate those conversations. But because everyone was so busy and often staff weren't on the ward, sometimes my husband would be calling and I seriously couldn't physically lift my arm up to kind of pull the phone down if the thing was aside from my bed. So it was very hard for me to maintain contact. I know afterwards that actually the ward did a fantastic job of staying in touch with my husband and keeping him updated on my condition, but nobody told me at the time, and of course I didn't know that was happening. My general feedback was that it was such a scary time for all of the patients and for the staff involved in caring for people with COVID. I had a fantastic experience of the kindness of all of the ward staff, from the people that brought the food to the people that the porters did all the cleaning, the nursing staff, the healthcare assistants. People were always kind. When people came to my bedside, they always told me who they were and why they were there, which was really important. And they were very responsive as well. Every time I had to call the bell, which was fairly frequently for the loo, and gallons of water that I drank. And just to stay with the kind of things that people did really well, people were so kind, and that was so important. So I'd say keep doing that. Kind of the values of people that come into the nursing and care profession kind of shone through. Keep doing it. Making sure communication is really clear. I would say the quality of care I got was excellent, but people missed some of the basics because assumptions were made about my capability, and just communicating and checking in. Have you got clean today? Have you had something to eat today? It's always the simple things, but that probably would have helped in my recovery.
Okay, I think that's quite moving stuff, and I'm going to pick up some of those ideas that Kerry spoke about in the rest of the talk. So sorry, it wasn't a video. It worked on Zoom. I practiced all morning. All right, so what were the aims of COVID Nurse? So COVID Nurse was to develop, in particular, evaluate the a nursing care protocol specifically addressing fundamental care needs of people in hospital with the SARS virus, with COVID-19 symptoms. And we were interested in comparing that and looking also at how nurses felt about using that protocol. So I'm going to tell you about how we developed the protocol, how we developed the techniques, and we did a number of things. But one of the most important things we did was a UK-wide survey of nurses and other people involved in direct patient care. We tried to find existing clinical protocols for fundamentals of care in pandemics. There aren't any, or there weren't when we looked. And there are lots of sort of, sub-protocols, but there are no protocols for fundamental nursing care in pandemics. And then we were interested in what nurses felt about their experiences caring for people. And one of the first questions we asked them was, what were the barriers to care? So these are 3 areas: physical care, relational care, that's the relationship you have with the person you're looking after, and psychosocial care. And it's no surprising that wearing PPE was regarded as the top barrier in all 3 areas. But there were some other interesting ones, like the severity of people's condition, a difficulty taking things in and out of isolation rooms, a lack of time, lack of personnel. I think that's changed. I mean, in the first wave, pretty much wards were locked down, and we didn't see, as nurses and direct care medics and nurses, we didn't really see as many of the other people around us as we'd been used to. Nobody knew anything about COVID-19. That was a big problem. And at the beginning, there was not enough physical resources, and that came across throughout. You need more stuff, because you can't reuse things. It's required, and of course, as mentioned briefly earlier in the Remembrance Day yesterday, the fear of catching COVID-19 was all too true, and the effects were heartbreaking sometimes. So these were the top barriers to care. But we also asked, well, what happened? And here's some graphs now, which I'll show you. These are 7 areas of physical care. We asked people, well, was the care worse or better or the same as the people that you were used to looking after? Because you remember, we were all shifted in, many nurses were shifted in to care in unfamiliar circumstances with unfamiliar condition. And the first point is, 1/3 of nurses in our survey said care for COVID-19 patients was worse across the board in these areas. And one area stood out for us, which was that more than half of nurses responding to that survey said mobility was worse. And I won't spend a lot of time saying why, but you can see when you're confined to a room, you're confined to a bed, you're confined to a small space, and you're fatigued and lying on your front some of the time, you're not going to get much mobility. You can't wander to have a shower like many people can do, or wander about the ward. So mobility was really impaired. I'm not going to circle this because this is really wow. I mean, in almost all areas of relational care, nurses said, care was worse for these patients. It was hard to establish a relationship, talking and listening, non-verbal, communicating with relatives. You've already heard in the introduction about that. And then finally, as a mental health nurse, I will circle this because it's a bit sad for me to see people saying, well, emotional well-being and anxiety and depression were worse for these patients compared to people I usually look after. And we have a very poignant video on our training materials of somebody talking about that, who saw some things when they were admitted that really got to them and really upset them. And that wasn't noticed at first. And all it required was a brief bit of mental health first aid, and nothing sophisticated, some acknowledgement, some empathy, and then somebody came and sat and listened to him for an hour from outside the ward, and that was enough for him. So that was a big problem. So here's the guideline. I take full responsibility for the cheese, which is, we called it COVID, because what we found was that there were 5 areas of difficulty: communication, organisation, values, interventions, and the D is the only way we could fit it in. Do remember mental health and emotional well-being. We asked nurses, how did you innovate? What did you do to overcome these barriers and to try to get care to the same level as you would expect to be given for your normal work. And they came up with 26 clinical strategies to address those barriers in those areas. There was also a section on leadership. And so what we did, we implemented it, and Jenica will talk about it, I'm sure. We had a guideline, we had some posters, we had an education program, and we really emphasized leadership from ward managers and senior nurses. So here it is. I mean, there are 11 strategies in communication, 11 things we can do to overcome those barriers and bring those graphs up to the same level. But how do you remember 26 actions? How do you do that? Well, you might have heard of this thing called What 3 Words. What 3 Words is a geographical concept. It's sometimes advertised on the telly, and every 3 meters square in the world has been given 3 words. So here's a great picture of why that might be useful. This is a great big sports stadium, and you're going to meet your friend, and he or she says, well, go to the club entrance. You think, where? What? There's thousands of people milling around. You can't see the signs. Where's the club entrance? You've got the What 3 Words app, and your friend says, go to Bunk Globe Fast. You put that into your app, and you end up in the same 3 meters square as your friend. Now, delivery drivers use that. I've done where's my home office? It's Hush Tried Store. Well, it's a kind of good idea, but it doesn't trip off the tongue, does it? Hush Tried Store. But we thought the idea was good. So here's some examples of what we did. We gave every single strategy, and here are the 11 communication strategies, 3 words that summed it up. So show and say is a good example. It's difficult to demonstrate empathy non-verbally when you're covered in all kinds of PPE. So you need to say things. You need to say things like, I can see this is difficult for you. You're telling me you're having a hard time at the moment. We can say empathy, and our eyes work very hard when we're in PPE, but sometimes we need to say. So show and say, good way of saying it. Chalk and talk, everybody did this, didn't they? Using whiteboard stuff. Put up on the window saying, oh, I just forgot this, please can you get it for me? Or this person needs to be have this need met at a particular time. So you don't have to go outside, take all your stuff off, put it back on, take all that time. You can communicate through this. So these were great suggestions from nurses, and I'm going to show you 2 more. Prompt and provide. This comes directly from Kerry, describes her issue, that prompting and providing. Actually, Kerry didn't brush her teeth for 6 days. There's something needed to happen her, and she would have done had she been prompted, but she was so fatigued she didn't genuinely remember. It was only when she'd been sick and she wanted to clean her mouth that she actually recognized that she'd not done that. So some pretty basic care. All she would have needed, as she said in the video, was just please remind me. And then I love this one, I am family. And this goes back to what I'm really glad to know that visitors are coming in more freely now. My experience, why I gave that experience about my wife helping me out, was precisely because we had so long without family, without significant others. And really what nurses have to do under those circumstances is think, I am family. What would those family members be doing if they were here? And they're not just sitting having a chat. They're often doing things with and for their significant others. So all these had this thing. So right, briefly, we did the clinical trial. It was a cluster randomized trial for those of you interested in scientific method, which means that we had a number of hospital trusts who carried on doing their usual care, and we had a number of hospital trusts, including yours, that were implementing the guideline. We were interested in what patients experience, so real solid nursing sensitive outcome. What's their experience of nursing care, and what were nurses' views about the gap between what they wanted to do and what they could do, which is what we call moral distress. We did it, and thanks, I always have to say a massive thanks to people like you for helping us. You can't do research without NHS Trust putting their shoulders to the wheel and working really hard. We had to change some of our targets, but you can see on this graph, we managed to recruit 581 patient participants and 418 nurse participants across England. Actually, we stayed in England. But you can also see on that graph some very fallow periods when, if you remember, those days when we only had 1,000 patients with COVID in hospital throughout the whole country. So there were many weeks where we were stuck without being able to recruit anybody. We weren't wanting people to be in hospital, but obviously towards the autumn of last year, the rates went up and we managed to recruit enough people. Now, I can't give you the results of the trial at this point because we only just finished collecting and sorting out the data, and my statisticians are analysing it now, and they won't tell me because I'm blinded. I'm not allowed to know. But I do have some really interesting data. Well, I'll just summarise and say that the guideline was developed by nurses, and somebody else mentioned a non-academic exercise. Absolutely was not an academic exercise. We really grounded it in real-world experiences of nurses and patients like Kerry. We built it up from those voices and from literature, and it is, I think, as I heard in the introduction, a rare example of a clinical trial in nursing care, led by nurses. All 14 or so of our principal investigators were nurses, and it was about nursing, and I'm sure we'll hear what that felt like from Jenica later. And it's actually one of the largest trials of pandemic nursing internationally, if not actually probably the biggest. I do have some data, and I just wanted to leave you with this. We asked the nurses using the intervention what they thought was important. We asked about the 26 strategies. We asked them how much they used it. I won't tell you about that, but I'll say that we asked them how important do you think those things were. Oh, they thought that everything is important, all 26 things. We're back to the amalgamation of marginal gains, aren't we? We as nurses, we have a tough job. We have so many things to think about. And so I think our challenge is to try to get all these important things into a system that means that we can remember to do them, so that Kerry can be very, very, very happy with her nursing care, but can still say, look, you know, there are some things which could have raised it from, you know, mid-medal table up to the you know, the high level that we saw of the Olympic guys. If you're interested in this topic any further, there is a conference in June in Oxford called Fundamental Care in Times of Crisis by the International Learning Collaboration. So I'll actually be telling you the results of the studies in that conference. So and there'll be lots of other interesting things if you're interested. So I will now. Oh, it looks like, have I stopped sharing? Yes, good. Yes. Fine. I'm done. Thank you.
Thank you, David. Are we welcoming Jenica? And then we could afterwards take questions from our audience online and with me in Waterloo. So over to you, Jenica.
Hi, I'm Jenica. I'm the sister on Anne ward, which has been taking the COVID patients since wave 1, and we're still doing that now. So Anne ward was predominantly an elderly care ward. So at the beginning, we did think, because we're quite used to giving interventions with ADLs, we almost under anticipated how that would be, because obviously we thought that's our bread and butter and we do that daily. What we didn't think about was that for a lot of these patients, they were a lot younger, how we were having that conversation with them. Particularly, we were seeing 16, 17-year-olds. It was their first time ever in hospital, and they'd just had a prolonged intensive care stay. So that was something in terms of ADLs, we felt like it was something that actually we still needed to look into. So with each wave, we had different challenges, and there was always something new to learn. And I think by the time this COVID research came out, we were at a point that we were getting really good at learning the research in terms of the new antiviral medications, looking at new trust policies, but we had forgotten around kind of what we're doing as core interventions for nurses. So when myself and Darlene and Heidi, the matron and head of nursing, looked at this, we read the COVID nurse, and actually, like David said, when we read it, it was quite hard for us to pick an intervention, because we were like, actually, they're all really important. Some of them, it was reassuring we already were doing them, but it was, how do we continue to build on these? And a lot of the things were, it is the little things that are making the huge difference. So the two that we picked was communication on who am I, So Fiona Hibbett's helped us get the a picture of all staff members, and we had our names, so it helped us introduce ourselves to patients, because we'd recognised obviously a lot of them didn't know who we were with our PPE on. And the second one was around do remember mental health and well-being. So in wave 1 and wave 2, we had recognised that we'd seen an increase in the need for psychological support for patients and how that was differentiating for each patient. But we felt like we still hadn't got that quite right with our resources. So that was something, again, we wanted to continue to build on within the trust. So the ways we managed to get these done is we discussed them in our huddles. We had an away day with the team. We discussed them. The research team were coming daily. The senior nurses did the full COVID research training in their own time, and then were paid retrospectively for them hours. And the junior members of the team were given time to do the select topics that we'd picked, which were about 10 to 15 minutes, and someone normally from the research team would help us kind of cover that shift clinically whilst they went to do that training. So we found it a really positive experience. We found that our family and friends test actually improved in these couple of months. The biggest comments we were getting around patients were kindness and recognising their emotional needs, which I don't think they were anticipating was going to be like a core nursing function at the time, particularly when numbers were increasing. It came at the perfect time in terms of staffing as well. It was when we were at a bit of a lull. Staff were getting at a point where they feel quite burnt out. The ward were very proud that they were a COVID ward, but then that only lasts for so long. So when you're getting into year 2, a lot of them were getting really fatigued. And actually to be involved in this, it really, really helped the ward morale, the team morale, staff wellbeing improved. It was something the MDT recognised as well. Some of the interventions we did, they also recognised and were kind of saying, oh, this is really important. It's something that maybe we should think about doing as well. So it really helped with us with our team, and I think it probably did help with some of actually the retention as well. And when we kind of have our one-to-ones with senior nurses, or when the team have their PDRs, everyone has written a reflection on nursing COVID, and quite a few of them have commented on the COVID research as well, and just saying that through such a difficult time, they've been allowed to now it's been a while and they've kind of can process everything. It's given them the opportunity to reflect and pull something positive out of something that was such a challenging time for everyone. So overall, it was really positive. I think it's really helped us give more effective care. Even the interventions we didn't do, I think we've recognised the other ones as well, and it's helped us to continue to embed what we're already doing and slightly change our practice and make sure that we're discussing these in our nursing care plans, in our handovers, in our MDTs, in our MDMs as well. And the team really took it in their stride, really enjoyed doing it. And I'll be interested to see the outcome of it. But it's been a really, really positive thing for both patient experience and staff on AM ward, and it's stuff that we're still focusing on and looking at continuing to do and build upon as well. Recognising as well that out of COVID, these are interventions we should be doing for all our patients as well. So it's been really, really good for us. I've enjoyed doing it.
Thank you so much, Jenica, for sharing your experience, and thank you, David, for this excellent talk tonight. To the audience in the room I am, and to the audience online, please do raise your hand, your virtual hand. Put on your video if you want to, or not. And I'll come to you if you have any questions, comments, thoughts, or even personal experiences that you would like to share with the audience. So, Verona, shall I come to you first?
Thank you. Hello, I'm Veronica Lavender. I'm head of Guy's Cancer Academy. David, I wondered, did any of your findings identify staff that were frightened to care for patients or frightened to approach patients? Because as a patient in critical care with COVID, I definitely experienced staff that were frightened to come near me, and asking for a paper cup with water. It would be put on the end of my trolley, then the trolley would be steered towards me. I was you know, I had CPAP, I was on continuous oxygen with nebulizers, I couldn't lean forward, and sometimes it was a struggle to reach across. I would have nebulizers put on the end of the trolley and again push towards me. So there was a definite sense as a patient they don't want to touch me, and I just wondered if you found any data about that.
Yeah, I mean, sadly, yes, that's true. It was one of the top 5 reasons, barriers to care, was fear of catching COVID that we got in our survey. And I think we have to remember that the sense of public panic that there was, that there isn't now, perhaps. I mean, maybe there should be a little bit more, I think, but right at that time, it was horrible, wasn't it? But the impact. Well, I also have stories, Werner, of people disobeying all the rules. You know, taking their gloves off and holding people's hands in those kind of circumstances. And you know, I think you can. People are people, aren't they? Some people will go one way or another. But I think the video. Sorry, you didn't see it, but the recording I showed you was similar, really. That Kelly was so fatigued she couldn't lift her hand up to get the phone. You know, so just like you couldn't go and get the water, and we didn't know those things. People didn't spot those things. Not some people spotted them, of course. Yeah. So yes, all what you said and others as well.
I must admit, I did experience having my hand shaken by the consultant anaesthetist, and that was the first person touching me, and it made such a difference. But that was the second day I was in hospital.
Thank you, Verna. We'll go next to Mary Malone.
Hi everyone. So thank you very much, David and Jenica. That was absolutely fascinating. I just wanted to, I suppose, really to endorse some of the things you've said from a slightly different perspective. I've been working on a study of student nurses across the 4 nations during COVID, and we've got a really large data set examining from a student perspective what helped them to function during COVID on wards and also to learn. And surprisingly, one of the strongest themes that comes through is around the feeling of psychological safety that well-formed protocols and strategies offer. Lots of the students say that they actually felt safer in the ward environment than they felt in the transition between university and ward environment, because once they were on the ward, they knew what they were supposed to do. And when they trusted the protocol and they trusted the strategy, they felt a lot of the fear of the experience was taken out. And that's something, as a nurse educator, I have to say I have never thought of before. So there's something there for us to investigate further, but also, I guess, to reinforce that the students, even in situations of real acuity, have a
So I think Mary has just frozen for a second. We might get Mary back. If I have just seen a comment in the meantime from Catherine Evans. Catherine, would you like to share your comment and your offer to Jenica to maybe write a piece for a professional journal while Mary is trying to reconnect with us?
Hi everyone. Oh, thank you. That's just been the most wonderful presentation. It was just so heartening, Jenica, to hear the reflections of your experiences, and you know, in participating in a research study, being asked to work differently. I was very intrigued to hear how the research team had, well, almost like backfilled for you so that your staff were able to undertake the training. And I just think within nursing, there is so important to be encouraging nurses to support research, to participate in research studies, that I would just really urge you to write a short piece for the Nursing Times, just to get that message out that this is something that is absolutely essential for nursing practice. And as you said, we really enjoyed this. And I think that would just be great for other nurses to hear, that participating in a research study is something that's been such a positive experience for you, and something that's impacted on your clinical practice in such a fantastic way. So I would hope that, you know, others working with you within the academy could support you to do that, but please, not onerous. And I'm sure somebody like the Nursing Times would be absolutely delighted to receive just, you know, a short article, just as you described to us this evening on your reflections. So thank you for sharing your story and your experiences.
Thank you, Catherine. Mary, would you like to?
Oh, thank you. Yeah, sorry about that. Sorry. So completely support what Catherine has said. Actually, I had almost finished. It was just to say that nursing students really do want to have that connection. And I guess it's our job to find out how best to give them the best opportunities to have it in. So no, thank you.
Thank you, Mary. We have a question from Julia Minge. Julia, would you like to come on screen or tell us your question?
No, thank you so much. And I was not expected to be invited in by Laurence, so thank you so much. I just, my question or my concern, I suppose, is how we move the presentation work that we have today, which is absolutely amazing, into the curriculum to enable student learning. Because that transitional work is absolutely crucial. And so I apologise. Laurence, you are very kind to invite me in. I wasn't expecting that to happen, but there is something about enabling students to navigate and have the conversation with their practice assessors and practice supervisors to enable them to move forward. Because I think there's a bit of a block around that. Thank you.
Thank you, Julia. So I'm just going to check if we have a question in the room. Okay, so would you like to... Sorry. And okay.
Good evening. I'm Dr. Maddie Blackburn. I'm one of the trustees of the Nightingale Fellowship. Sorry, there's an echo. I was really interested in the response, I'm not sure if it was Catherine, about her experience of actually the lack of contact by the anaesthetist, and actually that difficulty when you're a patient, but also you're a nurse or someone with an understanding of the healthcare arena, and how, even because of the fear of COVID, oh, something, have I gone, sorry.
We can hear you fine.
Okay, it's just a lot of echo and cutting out. How the question is how you overcome the barriers, particularly when you're a healthcare patient or patient with a, has knowledge of healthcare, and actually overcoming those barriers as a nurse when you're fearful of COVID yourself, but you want to support your patient regardless of who they are. Hope you could hear the question, sorry. And I don't mind who answers it, but obviously it was prompted by the amazing lady who commented about her experience. And many thanks to you all for an excellent presentation.
Well, perhaps while you're passing the mic back and everything, David, you might reflect on that and any of the other things, if that's okay. And can I say congratulations? It was a totally fantastic talk, both of you.
Well, to be honest with you, I'm really humbled by Jenica. I'm finding it difficult to say very much because she was so important in the study, and also the fact that as a researcher you can make a difference. Is there anything else that we try for? That's it. I find that question really difficult to answer, to be honest with you, because we went out to nurses and said, well, what did you do to overcome I mean, you know, you've got to maintain a level of infection control, which might mean that that you have to be restricted in the amount of touch, and what happens is that nurses feel quite distressed about that, and I think we've got this thing called moral distress, which is the gap between what you really want to do and what you feel you can do, and sometimes there's actually nothing we can do about that because the situation requires this. So I think we have to compensate in other ways, and that's why that communicating of empathy verbally, paying attention to people's emotional well-being and distress, which I'm really, you know, obviously as a mental health nurse, so pleased that you guys chose that as one of your areas of work. So I think we have to look at ways of maybe doing touch without touch if we can't touch. I don't know if that makes any sense, but I can't think of a better way. But I just do want to hold my hand up and say that, Jenica, your award was absolutely fantastic. Thank you so much.
Thank you, David, for answering the question. I think although we could take more questions later, we will now move on to the second part of tonight's event, and it is the part where we welcome our Nightingale Award recipients. So tonight we have Ugo Ogbonna-Godfrey and Sharon McDermott. So we will start with Ugo, if you are with us and ready. That's it, we can see you and we can hear you, I think.
Okay. My name is Ugo Ogbonna-Godfrey. I'm a midwife on the birth center, one of the coordinators. It's just to say that, you know, the Nightingale Award, when I saw it on the email, each time I would bypass, and, you know, time was ticking. And one of my colleagues, you know, had a chat with me and said, oh, are you applying? I said, no. And she said, why? I said, because I don't know what it's all about. She said, oh, let's sit together and read it, and then, you know, maybe both of us can apply. I said, that's good, you know, because I like teamwork, somebody I can talk to about issues. And we read what it's all about, and then applied. And I was pleasantly surprised when I was accepted. And even then, I was still a bit afraid, you know, because of work issues, you know, combining that with, you know, the reflective part. I said, okay, I'll forge ahead and go and listen to the lecture and see whether it's something I can do or not. I was very, very relaxed, you know, after listening to Irene Zeller, who is the module leader. And she made it look so simple and, you know, and enabled me, you know, encouraged me, you know, to say, yes, it's something that I can do. And knowing me, you know, I said, okay, I need to get this right. I went to like 3 of the lectures again, just to hear, you know, and be sure of what I needed to do. Here we go. The reflection was really, really in depth, because he opened my eyes. Not that I don't know about reflection before, but having to think deeply about, you know, what I'm doing, what I'm reflecting, and my practice, that really, really brought it home, and, you know, and it's impacted on the way I practice. Even when I want to talk to people, I'll be thinking in my head, how will somebody feel about the words coming out of my mouth? Am I saying the right things? Are people happy, especially now that, you know, people are on the edge, you know, sometimes you say something that is simple and people are not happy about it, or, and I'm thinking, are they well? Are they happy at work? Do they need help? Such things, make it more, having been to this training, it's made me to, sit back and think of my actions and, my words, even with patients. Am I happy the way I'm treating this patient? What can I do more or better to make them feel happy being looked after by me or my colleagues? And also, it also helped me with, PDRs, doing PDRs, I don't do any PDR without you writing a reflection, and then, me discussing it with you, to make sure that you really understand what reflection is all about. And also to have chats with people regarding maybe something I've observed, maybe the way they speak to their colleagues, or the way they've treated a patient, to have a chat and say, look, point them to the trust values about, respecting others, or how to strive to be the best, to be helpful, all around. So it's been a very good experience, and I am actively, talking to people, to embark on the course. It's a really, really useful course to do. And I thank Irene because, she's there to help, and she, helping and promoting and, spurring people, on, to complete assignments and to come to her for help and questions. Thank you.
Ugo, thank you so much for sharing your learning journey with us, and the impact that the Nightingale Award had on your practice. Thank you so much. We will take questions, but before that, we will go to Sharon McDermott, who is the other recipient of the Nightingale Award, and then we will take questions for both of you. Hello, Sharon. Thank you.
Hi there. How are you? I'm just going to share a quick slide. Ooh. Can you see?
Yes.
Oh, wonderful. So good evening, everyone, and thank you firstly for the honour of being able to share my experience. Thank you, Fiona and Lawrence, for asking me to join you. I obviously join you this evening to speak a little bit about my journey on becoming a Nightingale nurse. To introduce myself, my name is Sharon McDermott. I'm a recent practice development nurse in critical care, and I've worked here in Guy's and St Thomas's since 2016, where I started as a new intensive care nurse. When I first moved to London, I lived in Gassiad House, and on one of my mum's early visits, we went to the museums below. I'd always known about Florence Nightingale, as all nurses do, but honestly, not in any detail. We both found ourselves completely in awe of her and her influences to the quality of care that is expected and now provided throughout our trust, especially. Her strength affected how great foundations make incredible nurses through her schooling, all which resonated really strongly with me from my own education in Ireland. What really struck me, though, was her determination, massively her vision of nursing, and her leadership and progress in difficult times. When I heard about the Nightingale Nurse Award and the potential of becoming a Nightingale nurse, I realised it was something I was really ambitious to achieve. The Nightingale Pledge encompasses the underpinning values of the Trust, along with the aim of ensuring that all staff will always have the right skills to deliver care and feel confident as a member of the multidisciplinary team, which I think is so important. For me, during the academic reflections that I've explored through King's in becoming a Nightingale nurse really helped me to deliberate the pandemic and how we as nurses really, really put our patients first. While for me working bedside, I also taught surge nurses some additional skills for moving to critical care throughout the pandemic. And like everyone, I think we worked tirelessly we created teaching care for our patients. We achieved limits of kindness and compassion that surpassed all expectations of ourselves, in my opinion. And I really think we did all strive to be the best at our nursing selves. And for me, that's really inspirational. It made us like Florence Nightingale. I can honestly say that the aspiration of becoming a Nightingale nurse has kept me going while completing the award during the pandemic. For me, it was something to really aim for, to achieve, and to keep hope up. I completed it kind of throughout the second wave of the pandemic. So, you know, throughout the last 2 years, nurses have given everything. I think it's felt the award for me felt like something for myself. It was a kind of like a continuous light to keep seeking and guiding others and to uphold the continuous values and principles. For me, having received, oh sorry, next slide. For me, having received my award in June of last year and having become a Nightingale nurse, I think I continue to take the growth Florence was encouraging within our profession into my new role as a practice development nurse. Let us consider ourselves finished nurses. Let us never consider we must always be learning for the whole of our lives. I bring my passion for nursing and her legacy into my role, both professionally and academically, and I think it's really important. I strive to be the best both for myself as part of this Nightingale Award and become a Nightingale nurse, but while supporting others also to be their best and promoting this achievement moving forward to other nurses is something that I think is really vital. I am truly honoured to be a Nightingale nurse. I wear my badge with pride and I'm really grateful for the opportunity. I feel it massively connects me to the past, to all nurses gone before me, to my family of nursing, family of nurses, as we say, while linking me to the future brave leaders and Nightingales nurses of our profession. So I'm really grateful and thank you.
Thank you very much, Sharon, for sharing this with us. And thanks again to Ugo for sharing this as well with us. We are now open to questions, comments. Maybe Irene, I saw that, Irene Zeller, sorry. I saw that you left a comment for your students. If you wanted to come on the screen and share that with all of us, that would be lovely.
Thank you, Laurence. It's I have to say it's very inspiring working on this module, and it's been a delight since I took it on and led it from the beginning. It's been a delight working with Fiona. It's been a delight working with the staff. I feel humbled. I've read every submission that the staff have. I've marked them all, and all of them have been different, and all of them have been inspiring. And it really, I think some of them and very moving. Some of the accounts have been very moving, and I think what's been so lovely is the comments afterwards about how doing and undertaking this. Many people have either not studied in the UK before and this has been their first opportunity to do that, or it's been something they haven't studied for a long time. So it's really lovely working with staff and encouraging them and seeing them develop. And in fact, I had an email recently about somebody who wants to do further study as a result of undertaking this, which we always encourage them to think about doing as a stepping stone to that. So that's fantastic. It's just lovely. It's a nice module to work with and really delight to support everybody, and they do so well. Everybody does so well. So thank you.
Thank you so much, Irene, for sharing this with us. I saw Fiona Hibberts, you also left some lovely comments in the chat, and maybe you wanted to come on screen and share your thoughts with all of us.
Hi everyone, my name is Fiona Hibberts. I lead the award at the Trust with Irene, and it is fabulous to hear our awardees speak at this. I just love it, and Irene and I sit here and our hearts bubble over, and I wrote an opinion piece about my experiences because I thought whenever you're having a bad day, I invite staff to come and sit with me and go through the evidence of this award. And often a lot of people go out of my office are very different to when they walked in, because they've been heartwarmed about the real essence of nursing and midwifery and the care that we can give people every day. And I was really kind of overwhelmed with that real sense of joy. And I don't just mean a light, fluffy kind of joy. I mean a real deep-seated that this is what I'm doing and why I'm doing it. So to hear from Ugo and from Sharon is just wonderful. When you hear them putting their academic heads on, their reflective practice, thinking things through with their daily grind and putting it together. And it's that sweet spot, isn't it, that is just fabulous. And I think next year we hear from Avi as she hopefully will get her award this year and hear her experiences of it. Thank you.
Thank you very much, Fiona, for sharing this with us as well. Sharon, you wanted to respond, maybe? Oh, just.
Sorry, it was totally an error. I wanted to clap. But no, thank you very much. Everybody has been so supportive, and congratulations as well, Ugo. And thank you very much. I've really enjoyed listening to all of the speakers today. It's fantastic work that has been done, and I just think it's inspiring.
Well, thank you very much again to you, Sharon, and to you, Ugo, for sharing those wonderful experiences. Avi, I'll come to you now.
Yeah, I just wanted, firstly, just to say, thank you for sharing your experiences. Absolutely amazing. And listening to David and Jenica earlier as well. And also to Fiona, her passion and enthusiasm for this is overwhelming at times. It's just incredible. But mainly I just wanted to touch on a point that Ugo made in terms of the sheer anxiety and fear that some colleagues have about starting an academic program, particularly if they haven't studied for quite some time. And, hopefully I'll get a chance to tell my experience, but that is really, really real. And I'm just wondering, Fiona, I'm sure we do this already, but these stories are so, so powerful in terms of what, the experience of going through it and relieving some people's anxieties is how we use those. I know there's many, many, many nurses and midwives who will benefit, that haven't done this award, that would benefit from doing it for all the reasons that, Sharon and Ugo have shared. But there is still that real anxiety, just up until the point you start, I think, and then it starts becoming easier. But just taking that first step, and I'm not just talking about junior staff, I'm talking about some very, very senior nurses in the organisation who have a level of anxiety as well. But thank you so much for sharing today. It's been really, really amazing listening to you today.
Thank you, Avi. I don't think I see any more comments or questions. Let me know if I'm wrong. But if we don't have any more questions or comments, I will now pass over to Dr. Christine Taylor, who is the president of the Nightingale Fellowship and who will end this lovely event for us tonight. So over to you, Christine.
Thank you very much. On behalf of the Perseverance Trust and the Nightingale Fellowship, we're extremely proud of what we've heard tonight and very privileged to hear so many of you with relating your experiences. David started off with his personal experiences and how we can learn from them. And I must admit, when he started talking about the essence of care, it took me back to what we learnt was activities of daily living. So I was very pleased when Jenica actually referred to those, even though she called them ADLs, I was there with her. So the value of kindness that came through from listening to Kerry, although we couldn't see her, but we could hear her. I think the value of kindness throughout this talk has been has shown that it's been underestimated and perhaps undervalued. And thank you for those of you who've referred to it and what you've done and how it's touched you. And it's the little things that matter. For Ugo and Sharon, your reflective practice is inspirational. And we do love the garden that you showed us and the badge. I've got mine on tonight, and I certainly know we wouldn't be allowed to wear these nowadays because they'd be lethal. But for Hugo and Sharon, there's been over 100 participants at this event tonight. So everybody has been hearing what you've been saying, and Jenica as well. We've all taken inspiration from what you've said. Irene and Avi, you've come over as very keen and supportive, inspirational leaders, instigating the importance of researchers alongside nursing practice. We're all lifelong learners, and I was so impressed that reflective practice came in it, because that's what I got my doctorate in. And my final thought has to go to David, because what 3 words means something else to me. So I would actually ask you, David, could you let us know the what 3 words for your conference in June between the 13th and 14th of in Oxford, because we would really like to know where we're going, and we'd like to hear the results of your survey. Thank you everybody, and also final thank you to Lawrence, who's been keeping us all in time here. Thank you very much.
Thank you so much, Christine. And indeed, thank you to everyone, all our speakers. Thank you to Irene. Thank you to Avi. Thank you to Fiona, who has helped me lots and lots to organise this event. Thank you to Christine. And thank you to all our Nightingale Fellowship trustees who have joined us tonight. Thank you finally to Sharon and Ugo. And I'm sure I've forgotten other people, and I'm sorry about this. Actually, thank you to my colleague Paul, who's helped me as well this evening. The recording, as I said, will be made available. I will circulate it to all of you, and I will leave you with this, and I hope you enjoyed the rest of your evening. All right. Bye-bye to all.
Bye.